So that is an excellent question. And I think we can answer that in many ways. One of them is there seems to be an oral tradition in psychiatry where, you know, you go through training and people tell you things, and because of the huge volume of publications and topics being researched, we don't quite have, I may know maybe one or two people that could potentially be reading everything that is relevant, right? But the way to bypass it, because, you know, most of us, you know, with regular mental health provider jobs, don't have the possibility of being reading every major journal, you know, and more than that, not only you have to read everything, you have to make an assessment of the reliability of the data, okay? In the way to get around it is what I told you before, the kind of literature that you should be looking for that already does that for you, right? Which allows you a much deeper learning over a much broader number of topics without necessarily, you know, you having to go and read each one of those articles. Instead, you go and you read the ones that you know, have a specific interest or some topic you're trying to develop some further insight. So yeah, you know, I'll go for that literature that I recommended before, and we're going to review it later. But basically, examples of this thing we're talking about, this, you know, this sort of an oral tradition of psychiatry. So Lamictal is a medication that barely proved itself for what is approved, that is the bipolar associated depression, right? But for some magical reason, and that's another example, as we started with magical thinking in prescribing, is that every depressed patient out there is taking Lamictal. There's another statement, there's no evidence that treatment with stimulants leads to addiction, right? And I hear that all the time, people bring that all the time. That statement was made based on research performed with kids with ADHD, right? And what you find nowadays is that statement is used to justify prescribing stimulants to people that already have an addiction of any other sort, or even for stimulants, right? But and I had a few interesting interactions with colleagues over this argument, because they didn't even know where this thing came from. So that forced me to go and read and find where the statement came from. And the statement was absolutely not applicable to the population we're talking about. Chronic treatment with benzodiazepines. There's an army of people out there taking benzodiazepines every day, and we don't have any evidence suggesting it's okay to do so. And when we started to look into the long-term effects of chronic use of benzodiazepines, what we found was the very opposite. It's just a freaking bad idea, you know, and causes all kinds of problems. I mean, the patient comes to you and leaves with all his problems, and he leaves your office with a new one, which is pretty much an addiction. Lithium for borderline personality disorder, and because I know Pedro is recording this class today, I'm not going to badmouth all kinds of authors here that published saying, why is that? Because if you look times enough into a topic from a research perspective, eventually you have positive results by chance or by any other factors. And that's what gets, that's what the research is looking for, something, and then that gets published. That cannot make a book that has any minimal self-respect or that claims that is trying to teach something, because we have all kinds of negative results saying no, it doesn't. But if you look into something times enough, eventually you find something positive. That's not sufficient to justify a treatment with medications that have the sort of side effects that the medications that we prescribe. So we got to be more thoughtful than that, and that's the point of EPM. What is the best evidence available? The case of Lamictal, I have about 5 patients that swear by Lamictal, right? But that doesn't mean I should be giving Lamictal to everyone, trying to find the ones that will benefit from it. Because what's going to happen is what we spoke about gabapentin and Seroquel, right? The patient comes back saying it's good for him, he's not any better, right? But then you find out the addictive potential or the abuse potential of those medications. And so we don't know what we're doing in that regard. So we shouldn't be playing with people's health and life in that sense. This is one of the worst. If Suboxone works for opioids, then Adderall must work for cocaine and benzos for alcohol. Yeah, it could, but it was looked into it and it doesn't, right? But someone says that thing during training, and the next thing you know is that you have prescribers repeating that thing and hurting people accordingly. And UCAN is like, one example of UCAN is when you use augmentation strategies with antipsychotics, right? Yeah, you can. There's no data to say that it works, and most thinkable combinations of antipsychotics were looked into it, and the results were pretty like bad. Like really, we have like a handful of augmentation strategies, mostly involving clozapine or risperidone and Abilify, and that's it. Right? That's it. There's no point in this thing about tweaking medications that a lot of doctors do instead of going and giving the treatment that are supposed to be, prescribed to that patient.